Hello again. I'm going to move on now and talk about coming into the office. So you come into the office, and after you come into the office, there's going to be the history and physical. So we're moving on to the history and physical. Here, as I mentioned before, it's very important to have the information available so you don't have to waste a lot of time or get asked a lot of questions about items that you may have already supplied or have available to you. In particular, I'm going to talk about a few choice symptoms, shall we say. So, one of the questions that oftentimes was not asked in the office had to do with swallowing. There's a misunderstanding in the lay population that swallowing only occurs up here in the throat. But you have an esophagus, and so in medicine we consider swallowing to occur also in the esophagus all the way down to the stomach. So I told physicians, and in the book it says the doctor needs to ask, does food or pills or even water get stuck on the way down? You feel like something's getting stuck in your chest. I can remember seeing one patient in particular who had that symptom, but you had to ask for it. And if you didn't ask for it, you never figured out what was going on with her. But she had seen some other doctors and came to me in a situation where she really didn't know what was going on. But it was, unfortunately, it turned out to be esophageal cancer. And she did have food getting stuck in her esophagus, but you had to be aware of it and you had to ask the questions. The other symptom I'll talk about is chest pain. So if patients have coronary pain, known as angina, or they're having a heart attack, known as myocardial infarction, oftentimes they may not describe it as pain, but a pressure in the chest, and it may be characteristically vague. And it's usually not pinpoint and not reproduced with palpation. In other words, if I have a chest pain and it's located right here and you push here with your finger and that reproduces the pain, that is not heart pain unless you have different discomfort going on that you're not talking about. And people do have more than one thing going on a lot of times, and you have to discern that and tease that out. That's part of the history-taking skills that a physician needs to develop over time. So with the chest discomfort, we often will ask, how long does it last? When did it start? Where is it located? What brings it on? What relieves it? Does it radiate anywhere? Does it go down your arm? Do you have associated symptoms? Do you start sweating with it? And all of those items are often asked as part of the history. And the same thing applies to abdominal pain. Where is it located? When did it start? How long have you had it? Does it come and go? Does it radiate to your back? Does it radiate up to your neck? You know, all of those things can be important. And the medications are tied in with that in some cases. So if you have a symptom or abdominal pain that started when you started a medication, that's important information. So a lot of times what you want to do is put down, well, when did I start this medication and when did my abdominal pain or chest pain or whatever symptoms start? That can be very important. And you can even develop a flow sheet that looks at all of this if the diagnosis is difficult, and many times it is. With your medications, of course, you want your list of medications, what you've taken, the problems you've had with other medications that you might have taken. All of that needs to be spelled out. One of the first questions in my mind I like to ask is, could the medication the patient be on be causing the problem? This particularly comes up with cough, so chronic cough. These ACE inhibitors like captopril or these drugs that end with pril, PRIL, many of them do cause a cough. And I can remember a patient coming in and challenging me, well, doctor did looked in my lungs with a scope. He did all these tests. I never found out why I have this cough. And this patient was like almost half smiling, like, isn't this a mysterious thing that I developed? Well, the man was on an ACE inhibitor. So the only way to get patients off of these, as I've discovered, is you got to call the prescribing doctor and tell them what's going on, and then they will change it. Otherwise, a lot of times they ascribe it to some other issue. They don't change the medications for whatever reason. Maybe they don't want to deal with it. I'm not sure. So yeah, is the medication causing the problem? Back in the days of digoxin, you had to think about nausea with digoxin. That was a good one to think about. Dilantin can cause balance problems. A close relative who fell down, probably related to Dilantin. So you really need to, we really need to flush that out and be aware of it. Now, when you come in with your history and physical, they're going to ask you before you even get there whether you have a directive. And the directive is asking what you want to do if things go bad. In other words, if your heart stops or you quit breathing, do you want to be resuscitated? Do you want to be shocked? Do you want what's called a full code? In other words, if you're in the hospital and there's no directive and you have a cardiac arrest, your heart stops, or you quit breathing, it tells the doctors that you want to be resuscitated. You want to get on the ventilator if that's what you need, get shocked if that's what you need, whatever. On the other hand, if you don't want any of that, then you have to spell that out to your family, and you need to spell that out to whoever's making your directives. And the directives can be made by lawyers, or can even be made online a lot of times, but it's important that your doctors know what your wishes are so that you don't get resuscitated if that's not what you want for yourself. So the default, if you have no directive, is you're going to get resuscitated, and it's going to be a full code situation. So if that's not what you want, you need to have a directive in place before you come to the emergency room, or before you're admitted, or just go ahead and do it. I'm also going to mention that there is often a problem in the history and the medications when you're coming from the hospital or when you're coming from the emergency room. In other words, the changes that they've made, you may not be aware of, and your treating physician may not be aware of. Now, they go to, there have been some changes in the practice of medicine where they're trying to correct that, but it still happens. And so you need to be aware when you leave the emergency room or the hospital what those changes are, or have some kind of plan in writing. And usually the emergency rooms and hospitals are good at this. And you need to bring that to your treating doctor so they're aware, in case they didn't get that information, what the changes are. And a lot of times the outpatient doctors don't have access to the hospital records or the emergency room records. Now, they may have that access, and that certainly makes it a lot easier. But if they don't, then they're going to have to try to get that information. And sometimes they don't try to get that information. So anyway, you need to be aware of that. Now, after the history and physical is accomplished, generally speaking, we're taught to create a problem list. And that's a great idea, because you don't want to forget a problem. So, for instance, one of the ones that I ran into a lot was anemia. So if the patient had chest pain, abdominal pain, nausea, vomiting, diarrhea, all those become separate problems. And then if there's also a low blood count, that needs to be put as another problem under anemia. So all the problems need to be detailed out, and there's a lot of different problems that some people have, so that you don't forget about them, so they're not neglected or failure to follow through on them. That's very important. And then after the problem list is created, then there's a plan or recommendations that comes at the end. The plan is if you're the treating doctor, and recommendations if you're recommending to other doctors how to treat the patient. So in those recommendations, then you need to address each of those problems. And that is generally what's done in the history physical and the problem list and the plan. There'll be further detail about that later on.